It's a pleasure to have everybody here. We got together last night as faculty, and I was saying to everybody, the organizers and the rest of the faculty, how wonderful it is to have a dedicated symposium on deep venous disease and venous thromboembolism. This is the second year we're actually performing a dedicated venous content symposium at Link Mount Sinai, so it's a really wonderful time. The topics that we've been discussing the last few days, just to rehash, have really again been focused on deep venous disease and venous thromboembolism. We showed some, incredible didactic content yesterday on comprehensive contemporary management of DVT, touching upon how to treat chronic venous occlusions, how to minimize the risk of the post-thrombotic syndrome. Took a deep dive into venous compression syndromes and showed numerous cases of that yesterday to try and sort it out. Today we're going to focus on pulmonary embolism and IVC filters. So we're going to really look at probably the most devastating complication of venous thromboembolism, which again is acute pulmonary embolism, and then focus on the controversy that surrounds IVC filters. As I mentioned yesterday, pulmonary embolism is it's a huge cardiovascular health problem, not only in North America, but around the world. It's a leading cause of in-hospital mortality in the United States. And if you look at these statistics, it has greater mortality in the US than motor vehicle accidents, breast cancer, and HIV combined. So it really is a truly devastating cardiovascular disease. There's been a flurry of enthusiasm for endovascular therapy, I would argue without a tremendous amount of evidence to support it, and we'll try and sort of critically appraise what the state of the science is regarding endovascular management of acute pulmonary embolism, with fully knowing that we have incredible surgical expertise at certainly many tertiary and quaternary care facilities. Again, IVC filters in the previous decade were a tremendous growth area in terms of procedural technology and in terms of medical device technology. And I think everybody in the room knows that's been dampened quite a bit in the last few years, and we'll try and sort out who's ideally suited and what complications we should be aware of and what ongoing research is happening to define that. So I'm going to regroup and discuss the cases that we did yesterday, including one that unfortunately we couldn't film live, but we're going to sort of show you what we did with this case, a very, very interesting case. And then we'll go right into the session this morning on pulmonary embolism. So the first case that we showed was actually a very, very young patient who had a prophylactic a prophylactic inferior vena cava filter place in anticipation for abdominal surgery. And it was essentially 3 months later, he was able to be therapeutically anticoagulated, and we thought it was appropriate, as I think many do now, to not leave an indwelling implant in someone's inferior vena cava, and we decided to take the filter out. It was actually a relatively, what I would consider routine or benign retrieval. I think the entire case took about 10 or 15 minutes, but that patient is actually doing well. He's currently an inpatient, and his discharge is actually being planned. So again, just a nice case of our service being able to follow all patients where IVC filters are placed, and probably most importantly, to determine on a regular basis when is the appropriate time to remove the filters and get the implant out of the patient when it's sort of served its purpose. The second case was a unfortunate a lady in her 40s who had a fairly advanced venous stasis ulcer on her medial ankle, and she had undergone recanalization of a chronically occluded left iliac vein 5 years ago with what I would consider one of the first generation stents for that anatomic region, and unfortunately the stent had failed. This was the second time the stent had failed. She truly was living through the post-thrombotic syndrome with very, very significant symptoms: pain, swelling, and again, skin breakdown. So she came in as an elective case to reconstruct her again, symptomatic left iliac vein. There was a lot of discussion about what the relative role is here for the management of venous ulcers, of whether the iliac veins and the inferior vena cava can actually contribute to venous hypertension and how it should best be managed. We discussed that there are now actually 2 FDA-approved implants, stents for the iliac veins and the femoral veins, and we actually were successfully able to recanalize this patient with one of the newer devices, specifically a single long implant that extended from the inferior vena cava down to the inguinal ligament. And she did extremely well, was able to ambulate much easier after the procedure, was discharged yesterday afternoon, and again, subjectively early on, just said that her leg felt less heavy because her iliac vein had been opened up. So we'll obviously see her in the office and obviously follow her wound. The last case, as I alluded to, was a very interesting, challenging case. I'm actually going to have my fellow come up and present it to you. But this was a unfortunate elderly patient who had a permanent filter, which we've largely moved away from, I think, in our practice, certainly, placed for an appropriate indication. The patient had a symptomatic pulmonary embolism in the setting of gastrointestinal hemorrhage. But now came into office hours. Again, this was all done at an outside institution with very, very symptomatic bilateral lower extremity edema, post-thrombotic syndrome. This is 6 months after the incident event. Couldn't ambulate without assistance. A very significant lower extremity pain. And when we surveilled him, we found, again, this permanent filter and bilateral chronic iliocaval occlusions. And so again, a very, very challenging case. I'm going to ask my fellow Sumit Bal to come up here and sort of share with you what we did yesterday, and then I'll take questions.